Welcome, ladies and gentlemen, to the match between the world of endoscopists. A warm welcome to all of you for this fantastic evening. We have great umpires today, and I welcome the great umpires, none other than Dr. P.K. Shah and Dr. Narendra Malhotra. They need no introduction. They are world leaders. With more than 100 plus matches, we have had in the last 6 months. We have a pleasant climate and a dry pitch with negative scoring for the first time. This will be the best match the world will ever witness. Welcome to the Endoscopic Premier League. 2020 has changed and this concept has totally changed. We are learning fun, exciting, distressing, and that too with great scientific content and all evidence based. All the best, sirs and madams. Now, let's start for the program. I request our umpires who have just witnessed the toss to take the charge and I hand over the mic to them. Welcome, Dr. P.K. Shah, Dr. Malhotra.
So very good evening to all of you, gentlemen. We just had the toss, and the toss was the first match, which is between Dr. Krishna Kumar and Dr. Sudha Tandon, and Krishna Kumar has opted to bat first, and this is the topic is hysteroscopy necessary for before ART? So let me just tell you the rules. 8 minutes direct to both of you. 7 minutes you get a warning that the time you have 1 minute to wind up. If you finish early, you get -1. If you finish late, you get -4. And then you get 2 points 2 minutes later to rebut the other one. And then of course PK Shah will summarize what you spoken, and then we will have the audio. Not very foul language. You're allowed to use it below the belt or wherever you want, and you're allowed to use as many equipments or instruments as you want. But be careful, Krishna Kumar. There's a lady against you. 1803, sorry. Dr. Krishna Kumar.
So I start. So do I start? So today I'm here, the captain of Mumbai Hysteroscopy, for the first match of the season, where I'm going to talk on pitch evaluation and must pre-ART. I don't think any doubt about that evaluating the pitch before starting of the game is extremely important. And that too, when it's a match between the ball and the pitch. The pitch is bad, the ball will bounce back. We all know that. And ART is nothing but a good embryo coming onto the pitch or the endometrium. If the endometrium is bad, it is just going to fail and you're going to lose. So instead of relying on the direct evaluation of the pitch, if you examine through indirect methods, what will be the result? It will be catastrophic. How can you play a match without inspecting the pitch directly? I'm sure my colleague and my opponent will agree on this particular aspect. And this match is extremely important because it is all about the pitch. Though we have indirect evaluation, wonderful, but it is all operator dependent, good machines, then only you can get all such beautiful images. But still, even in a less equipped hysteroscopist, you can have a sensitivity and specificity close to 97 and 92%, and this is all evidence based. I don't think anything argument against this. Now, A great idea for the clinic ART physicians muted. Live birth rate was omitted and they went to cumulative live birth rate. Why? Because last few decades the live birth rates remained at 25-30% only. So cumulative live birth rate is like asking for an extra innings to hit the winning score. Repeatedly you do an IVF in my own center, then collectively for all those attempts you get a child, and then you say I won the match. How can it be by multiple innings for a single score or a single match? I don't think there is any denial on that part. And this very beautiful article published in one of the big books, Fertile Sterility, Time to Pregnancy, that means winning is important for patients and it is underestimated by doctors. It is a very recent article of March 2020 because couples who have not become pregnant and abandoned treatment owing to the psychological burden, and what they found was 50% changed the doctor after the first attempt. Even in USA, 65% without insurance car drop out. So the psychological stretch is more. So that means they abandon the match without completing the match. And globally also, 3 out of 6 IVF, where centers where it is countries where 6 IVF is free, even there 1/3 of the patients drop out after the first attempt because of the stress. And in a country like India, where the treatment patients have to pay from their own pockets, so they spend their lifetime savings to do in one attempt, the estimated patient without insurance is high, the dropout could be still higher. So to achieve that IVF's only boundary is what ultimately a child, ART specialists have fooled and started adding add-ons. List of add-ons have been increasing by leaps and bounds. I'm sure you will agree with me, Dr. Malhotra and Dr. P.K. Shah, and my opponent will also agree. It is like tampering the ball and the bat. The adjuvants are innumerable. Ovarian response, adjuvant to sperm, the methods in the laboratory, so many adjuvants. And if I to include the adjuvants of the endometrium, it will not get over in 2 hours. It is so huge because the pitch is more important. So you keep on adding adjuvant without examining the pitch. So that is the tragedy of IVF. And the FR, the Human Fertilization Embryology Authority, which is one of the bigger authority, now came into picture because of the so many adjuvants. It has clearly given none of the treatment on green light, which say that it can be used. Very few are amber colored, but most of them are in red. That means there is no evidence to show that if they are effective, they could be in fact dangerous also. So these are the list where amber colored are few, and one of the few amber colored you can see is endometrial scratching may have some benefit. Rest are all red and few are amber, which are all laboratory based and not clinical based. So add-ons to the ART, can we be honest? Are we cheating the empire here? Add-on only have added to the expenditure of the couple. Endometrial scratching has been given amber color, and instead of being helpful, they have been proven to be hopeless. So add-ons we continue to use, and to see the microscopic features of the pitch, hysteroscopy is the best. And we know that 9% to 67%, there are literature studies which show that recurrent pregnancy loss and almost 30% with recurrent implantation failure, these microscopic features which are not picked up by sonography, not by HSG or SIG, can cause problems. And if I have to just show you some of those features which are seen of chronic endometritis, you can just see the classical tuberculous appearance, the endometritis, micropolyps, shaggy endometrium, which is otherwise not possible to be seen by any other means. Direct visualization, direct biopsy, and on this pitch, if I try to put a best of the ball, it is going to bounce back or it is going to just go skid away and go. And you can also have this focal hyperemia in patients who have endometritis or hemorrhagic. There you can see. So biopsy, treat them with antibiotics, and then treat. Then you will definitely get. And there are enough studies to prove that it's
1 minute left.
allows the diagnosis of unsuspected uterine abnormalities in infertile women. And as an adjuvant, also it has been proved beyond doubt. And if the patient does not go into the multiple attempt, the CLBR is 0. So take home baby in the shortest possible time, hit a 6 and a winning run. with lot of balls to spare. So to conclude, to reduce the time to pregnancy, hysteroscopy should be re-evaluated, and definitely hysteroscopy is evolving in modern practice. Ambulatory hysteroscopy, take the DRS. It is time to rekindle that expertise for the benefit of our patient. They deserve nothing less and can be done without anesthesia, absolutely safely. So why not examine the pitch and then go for the, I would go with the examining pitch into the pitch. Thank you.
So thank you, Dr. Krishna Kumar, for finishing dot in time. It's 18:11, 18:11, exactly 8 minutes since you started. And as you can notice, he's taken the power play. He's batted on the front foot. He's led from front, and he has also used the DRS. PK Shah, your comments.
Yeah, I think I would like to tell my co-umpire, Dr. Narendra Muchala Malhotra, from Dr. PK Dadiwala Shah, that we will have to introduce microscopic pitch featuring henceforth in our matches, as suggested by Lord Krishna. So that is a very serious matter. Yes, but being an ultrasonologist, I feel that most of the pathologies of the endometrium can be picked up, and even the physiology of endometrium can be picked up with color Doppler and 3D. So though Dr. Krishna Kumar said that he would like to do hysteroscopy for tuberculosis and chronic endometritis, unsuspected uterine anomalies, all
Let
these
the
things.
other participants say this.
Yeah, okay. Okay. So,
Empire
So
is
I
not
think-
partial, I believe.
no, I am not at all. I am not at all, because she has already prepared and she's prepared the slides, so she is not going to add anything. So let's have the other side, the second innings by the opposition, that is Dr. Sudha Tandon, and she is from Central Mumbai, and she is a captain of Central Mumbai street cricket team, and she will be now opening the innings and hit Dr. Krishna Kumar's team. Let's see. Dr. Sudha
Your
Tandon.
time starts now. It is 18:13.
Yes.
18:13, 6:13 exactly.
Support, please send a share screen request to Dr. Sudha.
Please
Okay,
wait.
so time out. The share screen request had not gone, so we will wait for
Please
that.
reset. Please reset the time.
Yeah, so we'll take a time out for that. We'll not count this time because the share screen request has to go.
Support, please do the needful.
It's a technical fault from the support team.
Ma'am, have you received the request?
Not yet. Not yet. Can you see my screen?
No, not yet.
No, I have not got the request.
Is it because of bad light or rain?
No, there is no rain in Mumbai.
So we will have to do a Douglas Lewis here for adjusting the time and the score. The match has been called off for 2 minutes more. Otherwise, Dr. Sudha, you'll have to go without slides. Yeah, only two minutes we wait.
Good going.
Otherwise, she
Very good
goes
going.
for without slides.
On good pitches where you needed skill, look at that economy, which is a perfect bowler's job. That was a fantastic over from Dr. Krishna Kumar. Amazing.
Yeah, okay. So it's 18,
Yeah, we
14.
can
Can you
So
see my slides?
6:14.
Yes,
Yes,
we
we can see. Start. Your time
So
starts now.
my time starts now.
6:15. Your time starts now.
Okay. Thank you very much. My dear opponent has only been talking about the pitch. He's obsessed with the pitch. I don't know where is the ball and the bat in that. Let's look at the bigger picture. we have to look at the embryos and not only at the pitch. So let us see about this and what evidence do I have, what proof do I have, is lots and lots and lots of evidence-based evidence-based papers. So let us go through them, and I leave it to you to decide whether hysteroscopy is required before IVF, before especially the first IVF in all patients. So ladies and gentlemen, this is my proof and lots of papers. Now, whether it only depends on the abnormality of the endometrium. There was a paper which suggested that the problem with the endometrium was seen in 20 to 40%. And this was a paper which was presented in Human Reproduction, where they found what was the unsuspected, when it was not unsuspected on other problems. So hysteroscopy, how many problems were detected in how many patients. So they did this study, and they found that the 6% had polyps, submucous myomas in 1%, and adhesions in 2%, and septa in 2%. So the overall prevalence of any predefined intrauterine abnormality in this population, where the sonography and everything else was normal, was just 11%. So whether you want to do hysteroscopy in all patients IVF cycles, that would compensate for the cost raised by routinely performing 1,000 hysteroscopies. This was a very excellent conclusion that they came. And what they observed was that the further research is on the value of hysteroscopy as a routine procedure to evaluate uterine cavity is urgently needed. Okay, so then let me go to the previous one. This paper by Jyotsna Pundir, which was presented in Reproductive Biomedicine Online in 2014, suggested that hysteroscopy in asymptomatic women, so they are also talking like Dr. Krishna Kumar, prior to their first IVF, could be associated with improved treatment outcome cycle when performed just before commencing the IVF cycle. Now, there was a very good paper presented as insight. It's called as hysteroscopy before in vitro fertilization, which was a multicentric randomized control trials. So what was the interpretation? That it does not improve live birth rates in fertile women. It may improve the pregnancy, the number of women who get pregnant, but whether does it improve the live birth rate with a normal vaginal sonography, transvaginal sonography, when it is normal. So this should not be offered. That was the conclusion. So what was the problem with the previous study? That is what they were finding out. So they found that the previous study, there was lot of methodological weaknesses in the previous study, and these were all the weaknesses in the previous study, and hence that is why they came to that conclusion. And there was also one very interesting randomized control trial, which is a trophy trial, investigating the role of hysteroscopy in women with 2 or 4 failed IVF cycle. And even in this, even when there were 2 or 4 failed IVF cycle, hysteroscopy did not improve the live birth rates, which is consistent with their reported findings. So it's not always the pitch. It is not always the endometrium which is fault. If you're just looking at the endometrium and not looking at the other things, like looking at the bat and how the bowler is bowling, I don't think you can really score. This is what I'm trying to prove. So this was a very robust randomized control trial investigating live birth rates after hysteroscopy in women with a normal transvaginal ultrasound, which was done before the first IVF or ICSI cycle. So what was the conclusion? That it should not be done with a normal transvaginal sonography because it did not improve the IVF outcomes. So what are the modalities which have been already told? Transvaginal sonography, saline infusion sonohysterography, 3D sonography could possibly be more comparable to the accuracy of hysteroscopy. So although the number of women with intrauterine abnormalities were small, the findings suggest that it is neither useful nor cost effective to use hysteroscopy to screen for intrauterine pathology in women with normal ultrasound. Of course, if the ultrasound shows there's a polyp, there's a fibroid, there are some additions, please go ahead and do hysteroscopy, but please not in all patients is what I'm trying to say. So they divided the patients, randomized 750 women, 50% no hysteroscopy and 50% hysteroscopy. And these were the endpoints. And then they excluded women who were not to be included in that. And what was the conclusion? Mind you, this is a study of not just as one center, not just one person, but multiple studies proving this point, is that the clinical pregnancy rate, whether you do hysteroscopy or don't do hysteroscopy, is the same. Live birth rate is the same, and total pregnancy loss was the same. The biochemical pregnancy was almost the same. Miscarriage rate was almost the same. So this was the pregnancy data per embryo transfer. So if this is the conclusion, when it has been done in so many studies, where is the point in doing hysteroscopy in all women? That is what I'm trying to say. When the sonography is normal, mind you, I'm all the time telling, if the sonography and all other parameters are normal, where is the indication for doing hysteroscopy before your first IVF? And the time to pregnancy, the positive pregnancy test leading to live birth rate was the same, whether you do hysteroscopy or you don't do hysteroscopy. So why have the hysteroscopy done in this woman? And what could be the cause of implantation is probably poorly understood, and not just being obsessed with the pitch or with the endometrium. It could be either with the embryo or with the uterine cavity. And the most frequent causes is chromosomal abnormalities in the embryo, but the abnormalities of the uterine cavity, like the polyps, myoma, adhesions, which could impair implantation, are picked up by sonographies, are picked up by very good sonographies, which has already been told by Dr. P.K. Shah, our very renowned empire. So hysteroscopy is regarded as a reference standard to detect these abnormalities. Hence, it should not be offered to asymptomatic women scheduled for IVF. Okay, so this is another paper which was whether it improved.
1 minute left to wind up.
Yes, this was one more paper, and which also came to the same conclusion. So what are the NICE guidelines? It says that the NICE guidelines on fertility assessment and treatment state that women should not be offered hysteroscopy on its own as part of the initial investigation unless clinically indicated, because the effectiveness of this on improving reproductive outcome has not been established. And this is, friends, this is what I'm trying to tell. And I also inquired from lots of our very renowned IVF specialists in India whether they do it for all. Well, you can see the renowned names over here from all over India, and they say no, not for all. Definitely not for all. No, not before the first cycle. Only if indicated. Don't do it all cases. So this is what they all said. And so, friends, this is what even the same thing I'm trying to tell is, please do if indicated and do not do if not indicated. Thank you.
Time up. Thank you very much, Dr. Sudha Tandon, for opening up a new boundary line for this hysteroscopy versus no hysteroscopy. And now I would ask Dr. P.K. Shah to give his comments, and then we would go in for a rebuttal. Now, let's have the rebuttal first, PK.
Yeah, I think we'll have rebuttal first.
So we give 2 minutes to Krishna Kumar to refute all this about, Dr. Niranjan Chauhan, the Third Empire, wants to say something before that.
She has hit this 1 miles, great shot. Oh, it's a big straight over the top. The little lady has hit the big fella for 6. She's half the size, and she has smashed him down the ground. What a player, what a wonderful player, Dr. Sudha. Oh my God. Amazing.
I knew my opponent will throw bouncers, but they don't raise above my head. If I have to tell you about the insight and the trophy trial, it was match fixing. Nothing short of match fixing. It was now in the fertility sterility 2019 December. They said that the fecundity rate of that insight trial was 24 and 29%, and that they didn't have to explain. And they didn't account for endometritis patients having only 10%, and 45% of patients included in the other trial, trophy trial, had already undergone hysteroscopy before enrollment, which was not mentioned. So this was match fixing totally. That article very clearly mentions this. So this cannot be taken as a criteria. And improving reproductive, the debate never ends. In optimizing fertility, embryo culture conditions for the first 5 to 6 days matter. But so do anatomic factors do not matter. It has to be. Which is the most important deciding factor, my dear friends? And today, nothing worry about my cost, because low cost ambulatory hysteroscopy, we are all becoming masters and gentle and rapid, and we can use it without adding much cost to the thing. And hysteroscopy is my stethoscope, and I will create a perfect opportunity to reach the boundary for a complete evaluation. Thank you.
So that ball has been hit very hard. It is traveling towards the boundary for a 6. Let's see if Sudha can catch it or throw it back in.
I would really like to tell my proponent who says that every ball that one hits, it doesn't go for a 6. You know, it's not, you can get even you can get caught, you can get caught between the wickets. So it's not that just because you do hysteroscopy you're going to get a pregnancy. So that doesn't apply over here. So every time you hit, you're not going to get a 6er. And he was talking of preparing the to look at the pitch and not be preparing the balls. I would say that the oocytes and the sperms. What is the problem in enhancing the function of the oocytes and sperm by giving them micronutrients and seeing whether they are good? I don't see any problem. If your embryos are not good, what is the pitch going to do? So just by looking at the pitch, if you don't hit, if your ball is not good, if your hit is not good, it's not going to really work. And I think let's not be obsessed with the pitch and the pitch and the pitch all the time. Let's look at the bigger picture, because not always when you hit is a 6. So let's look at the complete picture and not just look at the pitch. So let's look at the entire picture. What I'm trying to say is that if the sonography is normal, if it
और
doesn't,
दोनों बल्लेबाजों ने इतने छक्के मारने चालू कर दिए हैं ये स्टेडियम के बाहर।
30 सेकंड है, 30 सेकंड और है अभी मैच के
बल्ले को टच करती हुई स्टेडियम के बाहर।
if your sonography is normal and if everybody is at the standard pattern, then what is the big point in doing
अभी hysteroscopy में sonography आ गई है. So that's it. The debate has gone off fantastic. Very well done, participants. Let's ask the expert opinion of Dr. P.K. Shah before we go for a vote.
Yeah, I think in ART, most important thing is not only the pitch, that is the endometrium, but also the seed, that is the embryo. Both are equally important. But you can't keep scratching the pitch before the match. So the scratching has to be kept out. And when you talk about microscopic,
when you take a leg guard, you have to scratch.
Yeah, it depends how much you sweat.
Because you have to save yourself.
Absolutely. But what is important is that today, with the type of ultrasonography machines that we have, 3D, saline infusion sonography and color Doppler, the physiology of the endometrium that you cannot see can be looked at with the help of the ultrasound, which you will not be able to make out by just looking at it directly with the hysteroscope. That is one thing which I feel personally. Number two, the tuberculosis, chronic endometritis, and other pathologies which Dr. Krishna Kumar talked about, I think can be very well picked up by ultrasonography. There is no need of invasive procedure. Irrespective of whatever you say, hysteroscopy is an invasive procedure. And there are complications related to it. Then Dr. Sudha Tandon said very correctly that by doing hysteroscopy, it may not improve the live birth rate, though the pregnancy rates can improve. I think what we are interested in fruits, what is the result, whether you have won or you are lost. So if you have won, that is more important. Dr. Krishna Kumar. Lord Krishna, are you listening to me?
Yes, I am very much there.
Yeah, and she gave you trophy also, the trophy trial.
Yeah, but
it was very clear.
That was match fixing.
Yeah, but whatever it is, you have to listen to this. That if transvaginal sonography is normal, there is no need of hysteroscopy. And I fully agree with that, because you have to go for nice guidelines, yes, but they are not so nice sometimes that you have to follow each and everything. It is all your practice, your experience, which will teach you how to manage a particular case before ART. Thank you.
The player wants to argue with the umpire. I cannot allow that.
Not argue. Just
So these are let's
because the umpires are all sonologists, so they are bashed.
No, I'm not a sonologist. I'm more of an endoscopist.
The third umpire is sitting here.
I'm more of an endoscopist than a sonologist.
Mind
So
is,
let's summarize for the audience.
no, let me tell.
Put it in your chat box, yes or no, endoscopy or no endoscopy. Let's see, now endoscopy and TVS, they are tools in your right and left hand, and they go together. We cannot say that we can do only by TVS. We cannot say that we can do only by endoscopy.
Right.
So you have to merge them together. There are plus and minuses of both, and it depends on who is doing what. It depends on the man behind. So it depends on whether it is Sachin Tendulkar hitting the ball or whether it is Bumrah bowling a bouncer to Sachin. So that's it. We have to match them, and both of them are equally important. The voting is in the chat box. We'll come back to you with the votes after the second debate. So Niranjan, you can introduce the second debate.
Yes, sir. Sir, before that, I want to tell you, there are a lot of many comments which have come here and the balls are going 4s and 6s. Dr. Tejal Soni, Mumbai, great initiative. Dr. Roshan Kongal, Kathmandu, nice to be part of this tournament. Dr. Rajesh, South Africa, Durban, fantastic. I'm reading comments which are just going bouncers all over the place. Dr. Khalda Huda Patna, very informative. Dr. Rama Garg, Patiala, superb. Dr. Sergio, what a concept. Oh my God, we have got a Spanish. We have got a
Sergio, the master of hysteroscopy.
Thank you, Sergio.
Amazing. And that was a wonderful tournament by Lord Krishna and Goddess Sudha. With great umpiring with style on hysteroscopy on one end and sonography on another. But let's summarize what sir has said. Both the umpires, I agree, both are the right and the left hands, and we have to be working together. Thank you so much. Now I call upon
This
the power
match,
play
before you come, there is a 1 minute advertisement break. This match comes to you with the kind courtesy of Juventus, the makers of Ferrona and Corellium Da3. So please have your iron and calcium after the match.
Wonderful, wonderful. Thank you. We will be getting the scores very soon for the first power play. Now we go to the power play number 2, and I call upon Dr. Pritesh Nayak to bat, and he's going to talk on sales. And it will be followed by multi-port laparoscopy by none other than Dr. Manjula Anagani. I hand over the mic to the umpires.
So again, for the participants, you know the rules. It is single port versus multiple port endoscopy, laparoscopy, and let's see whether we can do everything from sales or whether we need to drill holes 4 or 5 or 6 or 7 or whatever, and or maybe only with 2, where Manjula is doing operating. So Pritesh, your time starts now. 18:33.
Good evening, everybody, and welcome to the match, the IPL. The normal evening time when the day-night match is going on. Now, first and foremost, I must introduce myself, Dr. Pritesh Nayak from Mumbai, and thanks for the opportunity for allowing me to play this match today. First and foremost, I must mention 4-port laparoscopy has been on since a very, very long time, and operative laparoscopy since the 1970s by Dr. Kurtzheim. But since 1991, single incision laparoscopic surgery has been introduced by Marco Pelosi. We must know the instruments. Everything has changed. The instrumentation in sales is totally different. The telescopes are different, the proprietary ports, the instruments, the needle holder, and the manipulators. There is a total change in the instrumentation. This is how the instrumentation looks like. The commonest which we are using for the single incision laparoscopic surgery is a sales port. And the telescopes used are a 5 mm 30 degree or the endo-eye telescopes. This is how the instrumentation looks like. This is the endo-eye telescope, and this is the instrumentation at the outlet at the port on the abdominal wall. The proprietary port, the sales port, is the most commonly used, and the X-cone by Karl Strauss. Endoscopic instruments can be straight or can be pre-bent or roticulators or articulating instruments. The straight instruments are the standard bipolar, the harmonic, the scissors, and the vessel sealer cutters. And the graspers can be roticulator, which can be blunt, or Maryland. Specialized suturing devices like endostitch is used. Bipolar vessel sealers, the Thunderbeat, the plasma kinetic, and the N-seal and the harmonic are also used. Needle loaders by Covidin. What are the commonly performed procedures in gynecology? Hysterectomy, salping oophorectomy, ectopic pregnancies, PCOD drilling, ovarian cystectomy, and even malignancy surgeries have been described and done by the Taiwanese group. And so SILS can encompass the whole range of laparoscopic surgery. This is how the technique looks like. We always do an open laparoscopy and then introduce the SILS port in this manner, and the whole surgery has been done in this particular way, and that is how the abdominal wall looks like when we are doing the surgery. Now this is how the SILS scar looks like 15 days post-operatively. And can you see the scar 21 days post-operative? Well, this is absolutely cosmetic. What are the parameters of comparison with conventional laparoscopy? We must compare the operating time, which is almost the same, slightly more in the initial learning curve phase. The less the use of analgesics, the changes in the hemoglobin is marginal. There is no difference. Hospital stay is, of course, definitely less, and the complication rates are low, and the cost is just marginally high. And what are the difficulties which can happen? It can be due to the technique. It can be due to the tips and tricks for SILS hysterectomy is appropriate training, careful selection of cases, expert assistant, correct instrument set, and understanding their mechanism. We must understand the anatomy. Then we must use combination of long and short instruments. The suturing should be done by endostitch, and the closure of the port should be carefully done. What is the future of SILS? It will depend on equipment cost, the training, the surgeon skill, and technical innovations and professional enthusiasm. This is the most important part, the professional enthusiasm. This surgery is definitely not for the children. It is for the experienced laparoscopic surgeon who has mastered the 4-port surgery and then moved on to the single incision, more difficult surgery. But once you can do it, the outcomes are similar or even better. Hence, there was a need for innovation, and we have introduced even less invasive surgery, that is the STILS, the single trocar incision laparoscopic surgery, which is truly the keyhole surgery, in which the various procedures which can be done are hysterectomy, ectopic pregnancy surgery, salping oophorectomy, tubal clipping, adhesiolysis, sterilization procedures, PCOD drilling, and endometriosis. Myomectomy is the only thing which is not possible because it involves suturing, so one trocar you cannot do it. Instrumentation used for STILS surgery. We use the operating laparoscope, which is the 10 mm operating laparoscope, and long bariatric length instruments. So this is the most important part. This is how the instrument set looks like. Most important part is the operating laparoscope and the long instruments, and this is how the telescope looks like. This is the optical channel, and this is the operating channel, through which the instruments come out like this. So this is the only instrumentation and the only scar which is there. So don't you think it is absolutely cosmetic, and there is no need for the assistant also. I can do it alone on my own. And this is, I will just show you the video of this particular surgery. The standard entry is made by the Verys needle and the trocar. There is the instrumentation, which is how it is. The operating channel introduces the instrument from the midline, and wherever the telescope goes, the instrument will go. And that is the most important part. You don't need any assistance except from the manipulator which does the job. As you can see here, when I'm doing the hysterectomy, the smart movements are done in which the telescope and the instrument move together, and very carefully, without making any errors, we are doing the coagulation and cutting. Also, we can use the harmonic or the vessel sealer cutter, which is the new introduction. But this is definitely not for the boys. It is for the men to do this because it needs special instrumentation, proper training, and expertise in handling the instruments. Because there is no instrument to retract, there is no instrument to irrigate or suction at the same time. We are using only one instrument at a time, and the maneuvers are pushing, pulling, and retracting. And this is, you have to be very efficient in your hand movements, and both your left hand and right hand move in tandem. So as you can see here, I am coagulating the uterine vessels. That's all. So no assistant is there. Only the manipulating person is the most important part of the surgery. Well, the hysterectomy steps are done exactly the same like how it is done in 4-port surgery. As you can see here, the vessels are carefully taken, and right at the end, all the standard steps of laparoscopic hysterectomy are done, in which the other side is done, and then the vault is open using a monopolar hook electrode or a spatula over a vaginal tube introduced vaginally. There you are, but important part is do not cut the uterosacral, because we need a good vault support at the end when you suture this vaginally. So there's the monopolar functioning, and at the end, as you can see here, the whole surgery is being performed. Uterus is extracted vaginally after the whole separation. There you can see the uterosacral is not cut, and the vagina is cut, sutured using laparoscopy, vaginal route. Can you see the screen and the presentation still? This is how the vagina looks like after the closure.
So your time is up. Time is up. We cannot give you extra time. Time is up. Fantastic surgery, fantastic demonstration. And you did mention it's only for boys and men. We have very, very highly qualified laparoscopic surgery women in the panel and in the world. So let's see what Dr. Manjula, how Dr.
I need to share the screen. I think Dr. Ritesh has to go off.
Dr. Pritesh will lead.
Stop sharing your screen, please.
I have done so. I've stopped sharing.
Yeah, just now.
Yeah, now you can share. So
Right.
it's a boy-men surgery versus women's surgery, as he says. I'm sure, Dr. Manjula, you will counter that. Your time starts now. It is 18:42.
Thank you, Dr. Naresh Balhotra and Dr. Niranjan Shah. And the whole thing today is that I have my target very clearly fixed. I know what I am into, what I am going to do. But I have the advantage of dealing with something which is from 4 decades, like Dr. Ritesh has told, which is like tried, tested technique, which has the learning curve is over and everybody is able to take. He himself have come up with so many limitations where we are going to talk. So we have something which is a norm, which has become a norm to the patients and the surgeons even, and every surgery which is done by laparotomy can be done laparoscopically, even if they are not even too super advanced, but still it has to be a moderately trained laparoscopic surgeon. And when we talk about any surgery, we talk about safety of the patient and we talk about comfort of the surgeon. So here we are talking about the ergonomics, which are the most important thing when we have to operate for another 30, 20 years. I'm not here to retire. I want to work another 20 years. So my ergonomics are very, very important. So whether I'm doing a ipsilateral or contralateral, that is the most important thing. And the surgical principles, we have been taught a traditional surgical principles of traction, counter traction, and we want to simulate exactly the technique which we have learned over 3 years in laparotomy to be done in laparoscopy, which is impossible in cells. And the suturing, we need an extra endostage, or we have to use only barbed suture. We are not able to do the same, the triangular stitch which we have to do with the laparoscopy, which we have tried and learned. And learning curve is the shortest. In today's time, laparoscopy learning curve, because of so many training centers, it has become the shortest, and OR times are much, much, much lesser. Saying that, I can always go long time talking about the advantages to the surgeon and to the patient about multiport. But the relevant factors is, first, stills cannot be done for every case, very few cases, and in that cause when we are likely to take more for quadriport or triport, which Dr. Ritesh has shown, is likely to invest in the angulating instruments extra, is going to be more cost. And is it making a difference in the quality of life? No, it's almost similar. Surgical approach, technically, it is much more difficult. Like he himself said, it has to be done by a super advanced laparoscopic surgeon. And operating time is definitely longer because everything, multitasking is being done by one surgeon, and per operative, by the time you take out one instrument, put another instrument, and to see that blood loss is controlled, the greater blood loss is going to be there. And the post-operative complications are definitely higher because conversions is taken as a complication, and then the conversion rates to multiport laparoscopy is higher. Definitely at some time you might have to switch over to multiport laparoscopy, if not laparotomy. And the port site hernia incidence also is very, very high because with laparoscopy, with multiport, we use 5 mm ports for hysterectomy, except for myomectomy is 5 mm telescope and 3 more 5 mm for secondary ports. pain score is similar than we are using 5 ports. Additional further ports you might need with sales, but conversion to open or to multi-port and readmissions at the end of 30 days, if you take, there are quite a bit of higher incidence with sales, and length of hospital stay is almost similar. It is in fact daycare laparoscopies are in place today, and we have higher cases of daycare laparoscopy, higher incidence of umbilical seroma. We know that the more we dig into the fatty tissue, puppy fats, you're going to end up with seromas. Cosmetic. Let me talk about cosmetic later on. So disadvantages: loss of triangulation, clashing of instruments, lack of tissue retraction, which is the most important thing which we have given, the natural tissues which give way, and loss of freedom of movement. So difficulty with the suturing using traditional sutures, and more complex disorders like large myoma, severe PID, wherever is needed, you cannot do with cells. The most common exclusion criteria: previous surgery, previous mesh surgery around the umbilicus, and morbid obesity. So need for special access ports, and the port can just slip out, leak glass. So approach is technically challenging. Underlying principles are different. It has to be adopted and promoted by surgeons with advanced conventional laparoscopy skills. So are we going to say SILS is going to take over? No. The technical problems, like I said, is lack of triangulation. It's like sword fighting or chopsticks, which in India till now we are not used to eating with chopsticks. So we go up to articulating instruments. When we are going to articulating instrument, introducing them is difficult if it's the fixed instruments. So we take a pre-bent instrument. Pre-bent instrument cannot be passed to the conventional one. So we have to go to high-end, costlier ports. Then significant learning curve is there which is needed, and then there is a false pseudo triangulation which is going to come, and cross triangulation, which is very difficult for the routine surgery, our understanding of it. And then we have seen a beautiful deflectable tip laparoscope when Dr. Ritesh showed, but that itself is having a learning curve for the telescope to show it is. This is how it looks. It looks like chopstick effect, which is, I find it so difficult to eat even in the regular food. How people eat rice with chopsticks, I will never understand. So this is the cross triangulation what we are talking about. It might be useful only when you get advantage out of it, but otherwise no. But I'm actually going to talk about this particular complication we are talking about. Monopolar electrosurgery, which we have seen Dr. Ritesh using it. So much of monopolar through the cells. Potential hidden hazard for bowel burns. So this is what it is. There is a higher incidence of capacitive or direct coupled currents which are going to be there, and the suturing technique is different, and the conversion rates are almost as high as 10%, and additional complication rates is about 4%. And when the good gets going, the going gets good. So remember that when we are winning, let us win, and we have to come up with more techniques in doing it rather than sticking to what we have to come up. We can come up with newer technologies and techniques to improvise quality of life rather than making the comfort zone of the surgeons very difficult. So I believe in team effort. I believe in my assistants helping me, and that is where I stand. Multi-port laparoscopy
1 minute left.
Here to stay. So my 1 minute I want to utilize only to say that when cosmetic we talk about, it is overrated, because with a 5 port giving just a supraumbilical, you cannot search for a 5 port. And even if it's a ipsilateral, in the way we are done, complication rates are negligible. And you have the cosmetic 5 ports where it is, the scarring is tissue, it is individualized. So definitely when I have to risk with the cost and the cosmetic, and with hardly any cosmetic, and patient when counseled, 90% to 95% people are happy with the cosmetic results we give them. So here we are there. The multi-port laparoscopy is here to stay.
Thank you very much. Thank you very much. This debate has gone off very well, and we saw Pratish putting up in an Yorker, and that Yorker needs a very, very technically sound batsman to play it off. And of course, Manjula did loop the ball very nicely, and I think everyone could hit a six with that nice loop ball. Yes, Niranjan, your comments, and then PK Shah's expert comments. The voting is on. All those who are listening, go to your chat box. The question number 1 is hysteroscopy necessary before ERT? Yes or no? And the second question is, do you prefer single laparoscopy or multiple port laparoscopy? Single laparoscopic port or multiple laparoscopic port? If you want to vote for the question, if you want to vote for the person, it is Krishna Kumar versus Sudha Tandon, and it is Pratik Naik versus Manjula.
Thank you, my umpires. Audience, this is the first time we are talking about polling on a live Endoscopy Premier League. While we are making the subject so subtle and easy, I bow down and thank every one and each one of these participants and the dedicated umpires. See them, they are attired like umpires and they are so gracious to accept this wacky idea of a premier endoscopy league. The EPL team is overwhelmed, ladies and gentlemen. And I want to say you, there is a debate which is going on right now currently. And the poll one debate, histoscopy for all in ART, yes or no. It is the poll which is going on live. See your portal and you mark your tick. We will have the answer after the end of this debate. And the second debate is single port versus multiple port for laparoscopic surgery. One round is already done. We are waiting for Dr. Pritesh to come back and start his batting with the rebuttal. I got many comments, but I want to share only half a minute. Dr. Parag Rastogi, Muradabad, nice informative session. Dr. Anurita Singh, Meerut, clever mapping of the problem is the key to a good surgery. Dr. Trupti from Jamnagar, enjoy a lot. Dr. Girija KJ, Bangalore, she says to Dr. Nayak, Dr. Nayak, you'll have to hear this. Dr. Nayak, I don't agree with you as men or women surgery. Only thing is women are not foolish as men in a lighter sense. Each skill has its own limitations.
It is not boys.
You have time. You have time to rebuttal that.
Yes,
They caught the men and the boy remark.
I'm just saying what the audience is saying. I'm a third umpire. When the two umpires tell me to come into play, I will come. But right now I'm your host, and we are having 2,412 audience live doing this. Amazing. This cricket has gone overboard. I hand over the mic to my umpires to take over the field.
Prateek, you get your 2 minutes. Your 2 minutes starts now.
See, first and foremost, we should always talk what we should be trying and not what we cannot do. My opponent has an opinion that we should not try because it is difficult. You know, as our Dr. Rakesh Sinha used to always say, differentiate or perish by Dr. Malcolm Gladwell. So that is one. And come out of your comfort zone. All of us are good masters at 4-port surgery. We must come out of that comfort zone and try to give more benefits to the patient in those cases which are very selected. I am not mentioning that you can do all the cases, especially standard normal size uterus, PCOD, tubal clipping, adhesiolysis. These simpler surgeries don't make it universally 4-port or 3-port. We can always do this with a single port, single incision to get better cosmetic outcome, less pain, early discharge from the hospital, less use of antibiotics, and definitely the scar is cosmetic and the pain is less. We have checked the pain scores between all. So universally, we should not offer 4-port surgery rather than straightforward, more simpler surgeries. I am quite sure that at least 30 to 40% of our practice patients, we can do laparoscopy. I'm not saying you can do those broad ligament fibroids for hysterectomy. You can do pelvic inflammatory disease, pelvic abscesses by single port surgery. Well, all this is avoidable. But especially in those cases where you can do it, then we must differentiate ourselves and offer the best possible benefit to the patients rather than universally go. So if you cannot do it, we always put some additional 2.3 mm instruments to help ourselves, or additional single incision, multiple trocar, additional trocar on the side. So this always helps rather than straight go for 1, 2, 3, 4 and then trying to say, oh, it was a very simple case. I could as well have thought about the single port, and we should have asked Pritesh to come and demonstrate the single port. This also should not come to your mind.
Your time is up. Time up. Dr. Manjula, 2 minutes to you.
Yes. Dr. Pritesh went on telling about what is very important. I'm sharing this one slide. He went on telling we have to try a new technique. Agreed. We are not saying we should not try, but whenever a new technique or a technology comes into the world, it is a scientific knowledge, which is the one which will tell which technique is here to stay. So when it comes to technique and technology, we are the ones who give the technique, and the technology keeps coming by the pharmaceutical companies. Then we are the ones who have to choose which is here to stay. always the safety of the patient is important. You said pain scores, you said hospital stay. These are two things which are equally important, very easy depending on the other technology you use. You use harmonics, your pain scales are very, very less. You use less bipolar or unipolar, your pain scores are less. You have less peritonitis, chemical peritonitis because of the fumes which you are using, the pain score is less. So do not equate to the technique the pain score. Hospital stay in today's time, you always have a daycare surgeries which are there. Comfort is the main thing which is important for us to be long standing rather than going with the frozen shoulders. That makes us difference between what it is. Patient is always happy depending on what. So technically, difficulty. Complications, more with SILS, whether you say yes or not, port site hernias and the seromos are more. The limitations are there, costs are definitely higher, which you yourself have agreed. And when you said extra port of 2 point is put, it still becomes multi-port. It will never become a SILS. The cosmetic advantage, you have to remember that knowledge of the cosmetic is unique for every patient, and it more than 90% of the patients are always happy with the only need for the marginal improvement. And when we say scarless, there is a scar. It is not having a scarless is not, it's an improper word to say. You have to search, you will find it. And remember, last but not the least, is a serious investigation show that single port surgery increases the stress level within the team. Okay, and it's bleeding. Everybody, sir, it is bleeding. So we don't want the stress in the OT or us. So we are here at the beginning, and that's it. We win the match.
Oh my God, what a rebuttal that was, sir. That was amazing rebuttal, Pritesh. Pritesh, you're partly right. Some cases do require SILS, and I agree with you, but I'm not siding with anyone. I want to read some comments here with the permission of the umpire, Dr. Niharika Malhotra.
So you read out the comments, expert, and then I give you the result. The results are here.
The umpires are amazing. Niharika Malhotra, the umpires are amazing. And it's gone beyond this. Pritesh, you have placed that one through the offside field. Go and fetch that. Amazing. That's what Dr. Pritesh is saying. It's just going. And for the rebuttal, Dr. Manjula, I would say the Hyderabadi star is giving the Mumbaikar a real hiding.
Absolutely.
Absolutely, it's going fabulous. I hand over the mic to the umpires, please.
So the last comments from the expert umpire, Professor Dalial PK Shah, and then we have the vote. I'll announce the voting.
Okay, I think this was the most impressive and well fought innings by both the sides from Mumbai and Hyderabad, and they have tied up, and we will see the result with the help of the India voting for them.
The tie-up is only umpire's decision.
Nation wants to know.
The umpire is saying tied up. The public is not saying tied.
Yeah, public will decide for ultimately, but what is important is that single incision laparoscopic surgery, SILS, SILS, or STILS, single trocar, whatever you do, he accepted that it takes slightly longer time, maybe it has more cost, and that the training is required. I think he made it very clear right in the beginning. The only thing that he said in favor is the cosmetic, that there is only one incision in the umbilicus and it is not seen anywhere on the abdomen. None of the scars is seen. But what Manjula had to say is also equally important. That we have been learning and doing laparoscopic surgery for 4 decades with multiport. SILS cannot be done for all cases, as accepted by Dr. Pritesh, that you cannot do myomectomy where or any other surgery where you require suturing. The conversion rate is almost 4%. The pain score might be the same, but the port site hernia is slightly more in cases of single port. And clashing of the instruments, I think we have seen it. When you put it through the same port, so many instruments, there might be clashing. Obviously, that is for the person who is doing for the first time. They have to undergo training. What is important is that you can't tell all the Indians to eat food with chopsticks, as very rightly said by Manjula. It is not possible. Only few people can do it. Yes, and the learning curve is very long if you have to go for single port. Very nicely fought match, and we will wait for the results from all over India. Superb.
So, ladies and gentlemen, this EPL Thank you, Juventus, once again, Ferona and Corellium D3 for supporting these two teams and two matches tonight. Now we have, yes, I will give it to Niranjan before announcing the results.
While the nation is voting, kindly note that we are only discussing some techniques.
Yes.
We are not here saying that they are either right or wrong. Both are right in their respective places, and there is a scientific evidence being put forward by the pitch expert that he wants to see the pitch with hysteroscope, and ultrasound comes in the picture where Dr. Sudha Tandon, our player from Chembur Strikers, and we have Dombivli Kalyan Strikers. Both of them are going in the same direction and assessing the pitch with different modalities. But we are not here to judge. Both of them are advantageous. So just be the judge and choose the right method. Thank you.
So as far as the result goes, it is hysteroscopy versus no hysteroscopy for ART. As I told you, both are complementary. You need to do a good ultrasound for all the patients, and you need to do hysteroscopy for those who you have selected where there is recurrent failures, where there is everything. Now people take it as, when they put in the scope, they think this is the gold standard. Well, yes, till 3D and 4D, until contrast came, until the high definition Shalute imaging came, hysteroscopy was the gold standard, and I would have also voted for hysteroscopy. But today things are changing and things are changed. But the results still are that yes, a vote is 66% and the no vote is 33%. So 66% want to do hysteroscopy for all ART pregnancies, and 33% don't want to do hysteroscopy, and they will do it. So well done, but it is a technique. It is a technique, and वो डंडा नहीं हिलाने से काम चलेगा. So thank you very much, debaters number one. Yes, that is how you have to look into the uterus, and looking directly or indirectly. 3 years back, I would have also voted like this, but today I would have voted the other way around. So it's all technology and how you learn it. Yes, Dr. Niranjan.
Yes, sir. Amazing. That was amazing result, and I agree. That's what it is. You have to just be there around with ART, with hysteroscopy, and of course, the ball is in your court, and you can decide accordingly. Dr. Tarini Tarneja, अरे भाई आप लोग ने तो जादू कर दिया. This is what a comment which Dr. Tarini has given. It's amazing. I'm getting many comments. Something unique, something different. We are still waiting for the next poll result.
So the poll result of, yes, PK Shah, sir.
Niranjan, before Narendra gives the result of the second match, let me tell you, Dr. Krishna Kumar, that the match was not fixed.
Yeah, now
both the empires are ultrasound empires.
Yes.
Still.
Sir, you have to be very careful when you are choosing your words with the veteran umpires. But the India and the nation has given the side towards hysteroscopy. Yes, sir. Very important point.
IIG conference, IIG, not ASR.
So the second result
more laparoscopic surgeons around.
Yeah. So second result of obviously Pritesh, very well done, but we were expecting a result against SIL because not many people can do it, not everyone can do it, and it has got a limited indication and it's got a limited skill requirement which is there. But I am surprised to see the margin. 93% think that you need a multi-port, and only 6.6% are going in for the single port.
Still it is a sixer.
Yeah. So that is very good. At least six out of 100 still feel that single port is coming, and single port will be. Very well voted. Thank you very much, Niranjan. All yours to conclude the session now.
Amazing, Pritesh.
Thank you for asking us to umpire this.
Thank you so much, sir.
Thank you.
Can we take off the bells?
Yes,
Yeah.
sorry, sir. Sorry, please.
Can we take off the bells?
पिक्चर अभी बाकी है मेरे दोस्त.
I want to read.
Let's
There are many
open the
comments here.
champagne
I
for
want
the
to read.
winners.
Oh
Wow.
my God!
Wow.
Cheers!
That's amazing. So the winning team gets that champagne, and we will see to it that it's amazing. The first innings of EPL has come. We are just ending the program, but it's. I want to read few of the messages
Comments.
which have come. Dr. Dhruba Ray, Kolkata. Uh, MLS is better than sales. Well, already the result is out. Hysteroscopy not needed in all the IVF cases. It's my view. Okay, fine. I am with Dr. Sudha. Sudha, you have to be very lucky lady. Dr. Dhruba Ray from Kolkata is with you.
Thank you very much. Thank you very much.
Dr. Niharika Malhotra once again says superb innings. And there is Dr. Saraf. He's saying, I am awed by the attire, by the personality, with a hysteroscope in his hand and talking about the pitch all the time. Dr. Krishna Kumar, excellent presentation. Dr. Saraf. Fact remains that for a single port, you need to be a David Boone to play well. And Pritesh Naik, you have proved yourself that you are a David Boone. You are an extraordinary single person, which is a very unique thing in this planet, on this planet rather. And amazing, amazing. And you have got a lot of followers, I know. When you had come 1 week ago, amazing, 2,000 people had logged in. And I am a witness to it. They said, Niranjan, we want to play that video again, Pritesh Nayak. So we played it again for the benefit of the audience.
Thank you
That's
so
what
much
the
for a
na-
kind words.
And that's what the nation has seen today. Dr. Ganesh Bhatta, Bangalore, if laparoscopically is minimally invasive, vaginal surgery is not invasive, non-invasive.
Okay. So that was my comment. Single hole, multiple hole, no hole.
No.
No hole surgery.
Hole surgery.
But that is only for hysterectomy. That's only for hysterectomy. That's only for hysterectomy, not for anything.
It is not
Only
no,
hysterectomy.
sir. It is existing hole.
Natural,
Or existing hole.
natural hole.
This is also coming up
Natural
now.
orifice. Natural orifice. That's a right.
That's only for
When you
hysterectomies.
enter the peritoneal cavity, it is a hole. It is not invisible.
Sir,
She is very happy.
Okay, I think you can
Sir.
conclude the session, Niranjan.
sir, I want to read few comments with the permission of the
Yeah,
umpire.
sure.
Dr. Uma, wow, what a match. Excellent discussion. Loved it. This was a webinar with difference. And we will look forward to the complete series. Oh my God, Dr. Roshan Gongal from Kathmandu. When will be the other tournament? I don't know. We will search for a sponsor.
Be sure to keep the same umpires.
Yes. I don't think I'll be able to change the umpires because the
No changing of umpires.
the amount of expertise which these umpires have got is amazing. I think by the time I come for the second episode, probably I should not have a beard like Dr. Parmananda Keshav Shah. So I'm going to come very soon. Dr. Saurabh Birthare from Champa, superb umpires, excellent innings. Dr. Karki, when is the next? Yes, we will get back to you soon. On a serious note, all of you were wonderful, both the umpires, my gurus, my mentors, and the great debaters, Dr. Krishna Kumar, Dr. Sudha Tandon. Thank you, Dr. Pritesh Naik and Dr. Manjula. I would like to thank Science Integra, our team, Miss Meenal, Subbu, Shrimon, and last but not the least, our sponsors, Juventus, the makers of Corolium, who have been there today. Thank you so much. Because of them, we got this EPL, and enjoy your EPL. You will get this recording after 2 days. Till then, good night, Shabba Khair, Shubh Ratri. Fir milenge, new episode of Endoscopic Premier League and with the same umpires.
Thank you.
And the
Thank
same
you.
tournament.
Fabulously conducted.
Very much. Excellent.
Thank you.
Niranjan, fantastic.